At the Novartis Foundation, we're the founding partner of the HealthTech of Africa ecosystem, if you want, or a venture. Today, we're a slightly smaller group. I just tell you, you're kind of the first people coming into the house, which is going to be full in the next two days. So use the opportunity of today, because it's a bit more rare. You'll see how busy it gets in the next 2 days. So try to capture most of your connections today. Just to kind of activate and see how you can get out of here with at least one signed partnership. That's what my suggestion would be for you. So for those of you who don't know the Novartis Foundation, we are the not-for-profit organization of Novartis. We are a Swiss-based organization working around the world with the mandate of improving the health and well-being of low and middle-income populations, underprivileged populations around the world. We do it by partnering with smart organizations, such as many of you guys in the room, with governments, and with the power of data and technology. About several years ago, exactly in December 2021, this building and this stage did not exist, but the building of the HealthTech Hub Africa was the first one in the Norsken House Kigali, where we are gathered today, which opened its doors to host what we call the HealthTech Hub Africa. Who of you actually knows in depth what the HealthTech Hub Africa is and what do we do? Raise your hand just for me to kind of get a clue. Okay, 1, 2, well, okay, good, not great rate, but we're getting there. So the HealthTech Hub Africa is a Pan-African accelerator. We're a zero equity accelerator. As mentioned, the Novartis Foundation and the Norsken Foundation, who are our hosts, started it exactly about 2 years ago. And our focus is probably a little bit different than what our other good friends in the ecosystem are doing. We're focused on accelerating, first of all, finding the best-in-class health and technology startups and scale-ups in Africa, accelerating them, and helping them look at the opportunity to either innovate in terms of public-private partnerships or look at the opportunity to create business-to-government monetization models for their companies, for their organizations. So if you have to think of why are we doing what we're doing at the HealthTech of Africa, you know the African continent has so many health challenges. We all know that because all of us work in the health sector, or most of us work in the health sector here. People talk often about the lack of health workers, for example. But what people don't often talk about is the opportunity which comes with a huge amount of young people entering the workforce in exactly 7 years from now. To be precise, you would have 375 million people entering in 7 years from now the workforce in Africa. There is a huge opportunity. If all of these people enter that medium space between health and technology and are capable to innovate that space, this is where actually some of those big public health challenges are going to be tackled with the power of partnerships. And this is why actually we started working on the HealthTech of Africa. On one side, we focus on the problems of the startups, which means we provide acceleration support services, business model innovation coaching, mentorship, access to incredible amount of benefits from our partner network. We also provide funding opportunities. They're not just any type of funding opportunities. We provide what we call it, in a way, acceleration capital, which is tied to specific government priorities. So what we're saying, in other words, is we look at what are the big public health system challenges. We sit down with specific governments around the table, or regional governments, meaning a set of different countries, and we try to map out, based on all the funding that we have available through our strong partner network, and not only financing but also in-kind support, how we can actually source and coordinate and streamline this funding to particular acceleration use cases, so that the startups actually can validate, test, accelerate, and scale their solutions in public-private partnerships. This is very attractive for our investor community. Who is an investor here? Raise your hand if we have some. All right, brilliant. So being an investor, probably you're thinking, oh my God, that's great because they're giving grants, right? So we started with the Novartis Foundation. Then in the end of the first year, we had our great friends from the Global Fund and the Patrick J. McGovern joining as our anchor partners, which means that now we're a much stronger community. And we have even a bigger announcement later down in our agenda. I see some friends from the African Development Bank in the room, and we have other friends from the UBS Optimus Foundation, which are going to also join us in the next days. But what it is to say that our third pillar, most important, is the network of public and private partners. We started like 3 organizations. 2 years later, we are over 15 public and private partners, including we have government champions from the government of Rwanda, who opened actually the HealthTech of Africa with us, the governments of Kenya, the governments of Senegal, Cameroon, Nigeria, and very soon Ethiopia and several other countries. So all of them capture the problems which they hear. They really listen to the startups, they sit with the startups, and they look at also the regulatory landscape. What are some of these policies and regulations which make it impossible for startups and scale-ups to really even test their solution, or maybe scale it or bring it from one market to another market? So this is one big topic of the HealthTech of Africa as well. So in other words, what are we? We are a platform to bring support, to bring coordination, and convening the right kind of partners who want to accelerate African solutions for African health problems. I'm super grateful to host all of you here today with our incredible team from Bridge for Billions, who has been implementing this program for the last 2 years. We have been supported by great organizations such as Norscan, the Norscan Foundation, Village Reach, which is leading our work around public health policies, and a number of other great partners, such as the Center for the Industrial Revolution, who are our experts in all topics around Rwandan policies and regulations for innovation, and a number of other organizations we are going to meet in the course of the next days. So what is on the agenda today? I'm going to stop to speak too much. I like to keep this very short. Today is a bit of an exceptional day. As I said, the room is slowly starting to fill. But we wanted to start with a bit of a soft introduction towards the investment topic. What you're going to see in the next days is first you're going to hear and get a flavor of some of the expertise of some of our partners. You're going to hear from 2 fantastic partner organizations, Microsoft Philanthropies AI Research Lab, and you're going to hear from Nuvotech, one of our great South African SME partner organizations, on very interesting topics, followed by 2 full days full of investor focus sessions. So success stories from some of the actually accelerated use cases, startups and scale-ups who receive funding, looking for follow-on funding and partnership opportunities, but also investor-ready startups from our cohorts. Today we're launching, essentially speaking, we're kind of like finishing the 2nd cohort of the hub. And if you're asking what was the impact so far, we can tell you that in the last 1.5 years of the program of the hub, and we're talking about just 1.5 years, the end of year results are going to come a little bit later, we have managed to support 68 African startups and scale-ups from 17 African countries, which created more than 800 paid health and technology jobs on the continent. They raised more than $18 million in funding, and they, yes, please applaud there for them. And they touched over 2.4 million lives directly, their beneficiaries, so direct patients, nurses, physicians, really the people who are benefiting from their solutions and services. So we have some incredible innovators that you're going to meet. Some of you are already here, some of you know each other. If you don't know each other, please try to speak to different people throughout the course of the next few days. And with this, kind of my part here is done, right, Sharon? Unless I missed anything, and I'm handing it to a good friend of mine, Bill Wicks from Microsoft, who is going to tell us all about the great work that you guys are doing. So please tell us more about yourself and what you guys are doing.
Hi, I'm Bill Weeks. Nice to be here. I'm the director of Microsoft's Philanthropic AI for Health program. And I will talk to you a little bit about what we do in our AI for Good lab, and then some ideas about what we've learned, and maybe some ideas about what the future of AI has to help solve the world's problems, particularly around healthcare. So we have a senior leadership team of about 7 folks, and under that team is about 35 different data scientists and data visualizers that work with us on a variety of areas. The general approach that we use is one where we get a data set that is already there. We don't really collect data, or we're not in that business of collecting data, and we store it. We use Azure to store it. We design some solutions and do some analytics around that using these data scientists that we have, and then we work again with our partners in thinking about how to implement findings in a way that helps improve the health of the population served. And we kind of circle around that. These are different roles and activities. In the AI for Good lab, the broader lab that we have, there's 3 focus areas: sustainability, humanitarian action, and health. And I'm just going to give you some examples of what we do in each of those areas. Sustainability is obviously about climate change and making the world livable, which is really critical for the health of the world, right? I keep kind of trying to say that all the sustainable development goals all have one central target, which is health and well-being, right? But without that as a target, the other stuff kind of doesn't matter. So sustainability, all of these in my mind, I'm a physician, so I'm biased, but all of these in my mind are directly related to health. So sustainability, one thing we're trying to do is to identify cropland in Virginia, for instance, to see what the status is of the cropland and how different crops are actually growing, and what's the, where are they in the cycle of growth. And we use satellite data. We partner with Planet to get satellite data. It's tremendous. It can kind of give you daily updates on what's happening as long as there aren't clouds in vast parts of the world, and you can then analyze it and see what's happening with regard to crops and other things. We do the same thing. We use satellite data to identify climate-related activities. So here, for the first time in the U.S., we have the Department of Agriculture, which tries to monitor poultry farms. Poultry farms can cause all sorts of havoc in water and in the environment. And most of poultry farms are kind of self-regulated. They're sent a survey every 5 to 7 years, I think, and they fill out the survey and they talk about how large they are. The Department of Agriculture misses a lot of those. People, particularly the smaller ones, don't necessarily turn in their reports, and so we were able to use kind of the way that poultry farms are organized traditionally to identify across the entire country where poultry farms are, and to help then the U.S. Department of Agriculture identify them so that they can monitor growth of these things and look at particularly new ones or things that have grown quite a bit and target them for kind of regulation and understanding where to go check things out. And then even thinking about animal behaviors and the impact of climate on animal behavior. Here we're looking at giraffe behavior and the way that giraffes interact with one another in different communities in Tanzania. And it's interesting because up here they're kind of limited. You can see they're geographically limited by a lake, so these guys all stay together. There are 3 other groups of giraffes that interact with one another, and so their kind of genetic diversity kind of increases over time. We work in humanitarian action. A lot of the work here is trying to identify where there's been crises, where, whether it's earthquake or war. Here, this is using satellite data to identify post-disaster building damage, and I think this was in Syria after the earthquake, in Syria and Turkey. And here you can look at, again, using the satellite data, look at before and after information, and immediately be able to identify where there was substantial building damage, which is really incredibly important because it's very dangerous to go there, and people cannot go in when there's an ongoing problem. In fact, in the recent fires in Hawaii, we were able to identify much quicker, within a couple of days, what the extent of the damage was than the people on the ground, because it was dangerous for them to go in and assess that. So using satellite data is kind of tremendously important, and it's a great opportunity not only for this kind of thing, but also eventually, I think, for health. Here we're looking at survey data and geolocators to anticipate food insecurity in Malawi, and looking importantly at kind of what are the factors that drive that in this upper thing on the right. So we can identify where the opportunities for food insecurity to raise its head are, and figure out the reasons why people are more susceptible for food insecurity in those areas so that governments can intervene. And then here we're trying to, for instance, improve accessibility for people who are blind, identifying currencies and using a very different approach to identifying currencies so that blind people can scan the currency using a phone or something like that and get a sense of what the currency actually is in a very novel way. In health, we here, the idea is maybe to, there's a scarcity of health workers, right? And similar to satellite use, you can use other imaging technologies to help identify people who are at risk of a particular disease entity and then steer them toward the scarce resources so that those scarce resources are better used. And here the example is pediatric ophthalmologists. This is retinopathy of prematurity. What happens is kids who are born premature are susceptible to their retinas, the back of their eyes not developing. If their eyes don't develop well, and there's not an intervention which is fixable, you can laser the back of the eye, but pediatric ophthalmologists have to do that. If that doesn't happen, the kid can go blind. It's the biggest cause of blindness in lower and middle income countries, where more and more kids are surviving prematurity, right? It used to be they would just die, now they live, and now they're susceptible to this disease. So what we've been able to do is identify or use an algorithm where you just take your phone, and a community health worker can use a magnifier on a kid, and through a two-step process identify whether the kid is at risk of retinopathy of prematurity. So take a premature kid, use your phone, and it gives you first an indication that you got a good picture, right? So it takes the video and it says, yes, there are good pictures of the retina, which is really important, because if they put the kid, they've sedated the kid, they've kind of bound them, they're young kids, they move around, it's tough to get a good picture. If they don't get a good picture, then, and they send the kid home, they've done nothing, right? It's kind of defeated the whole effort. So here we just can screen and say, yes, there's a high quality picture within the video. And then the second thing is, does the kid show indication of retinopathy prematurity, yes or no? If it's yes, the kid can go to the pediatric ophthalmologist, which is very scarce. The key thing is that the pediatric ophthalmologist is no longer the one who's doing the screening. The screening is done by the community health worker. So you've now taken what's probably 80% of what the pediatric ophthalmologist used to do, which is screen and eliminate most of that. So you've tripled the pediatric ophthalmology workforce, in essence, by doing something like this. More kids get access, more kids are directed to the care that they need, fewer kids go blind. Here we're looking with Novartis Foundation at the relationship between social determinants of health and health. This is in New York, and we're trying to use predictive analytics to figure out where, for instance, people are more likely to have diabetes based on the environment in which they live. And I'll get to this later and expand on that a little bit later. And here we're looking, for instance, look at large data sets like search data to see whether we can anticipate opiate overdose spikes in an area. And indeed here, when people in Connecticut began to search for fentanyl, and you saw a peak in the search for fentanyl, a few days later there was a peak in overdose deaths, right? Which kind of makes sense. So you can imagine people who want to intervene, they can get Narcan out there, they can actually solve the problem in anticipation of the spike in deaths. They could prevent the deaths by intervening given this information. So those are just some examples of the kind of work that we do across all the areas. I'll tell you kind of how we work with partners, and they're generally not-for-profit partners. We can do this in two ways. We can just provide Azure credits so that people don't have to spend money on credits. This works pretty well if people are in a data collection phase, or if they're going in for a grant where they need to have, like, NIH is going to fund them, and this helps kind of defray some of the costs of the overall work of the grant. And the second way we work with them is we provide some credit sponsorship, but we also have data science expertise. Those 30 some odd people that we have who have data science expertise will work on a particular project for a specific amount of time, with the idea being that the data are accessed through the partners' Azure tenancy. The IP that's developed is the partners. We have a commitment to open source the code and data sets if possible. We co-author an academic paper, and it requires that we go through some legal hassles kind of to get that doable. And we have several areas of interest in health now, focusing more on health for this group. Computer vision, where we do segmenting of organs and cancers, for instance, on MRI scans or CAT scans. Also looking at ultrasounds and their use for screening, and actually thinking about ultrasound as a possibility for creating two-dimensional MRI quality film equivalents, because ultrasound is much more portable and cheaper than MRIs or CAT scans. Looking at pathology and the diagnosis of particular types of cancer based on AI analytics, and then edge use of AI for diagnostics, for instance, looking for schistosomiasis in a microscope scan of water to see if you can identify schistosomiasis in the area for early intervention there at the point of care without having to send in slides to a third-party lab. Public health, social determinants of health for city planning, and also these large data set analyses, working with BRAC, for instance, on maternal fetal health, and looking at sudden unexpected infant death syndrome as another area. And then these large language models, this is ChatGPT, right? This is what everyone thinks of when you say AI. They just think of ChatGPT, and they think that there was no AI before that. But there actually was, as you guys probably know. And here we're looking at data summarization with working with the WHO, for instance, who gets all these data in all these different formats and all these different languages coming in. How can we kind of summarize this very quickly so it doesn't take quite the labor, and the answers, the solutions can be developed much more quickly. And also things like guideline development, where we're working with Kaiser Permanente, who develops guidelines on hypertension, for instance. When you do these kinds of analyses, you have to look through thousands of abstracts and hundreds of papers to develop the next guideline. It takes a lot of labor. It takes 4 or 5 years to do this, and things happen in the next 4 or 5 years. So the idea is to unleash the large language models on the medical literature, where there's thousands and thousands of papers coming out every day, to help summarize things, help focus on the papers that need to be reviewed by humans for the development of much quicker and more accurate and more up-to-date guidelines. This is how we evaluate opportunities. We want to make the best investments we can with our limited resources. We're not a huge group in Microsoft. So we want to make sure that the data that are there are available, they're current, they're usable, and they leverage our capabilities. So that's why we focus in those 3 areas. We want there to be alignment with overall Microsoft goals and with our internal interests. And then we want to have big impact. Sometimes they're really cool projects, but they're just not going to have a huge impact. I think the key thing here is to think about not only the impact on something like retinopathy of prematurity. It's a growing thing. It can have lifelong impact on kids. The key thing, though, is how do you scale beyond just one area where the project might be happening, right? So there is kind of thinking about who are the partners of the partner who can actually have the thing scale so it has a bigger impact worldwide. Okay, so now I'm going to focus a little bit. So think about now you guys and how you might engage potential collaborators. You guys are the new generation of tech here in Africa. So how might you engage folks? As some of you may have heard and experienced, there's a bit of hype around AI, right? It's the solution to everything in the world. It's going to either kill us all or save us all, one of those, and there's no in between. And so, you know, there's all this hype going on, and people are very excited and very scared at the same time. And what we've kind of found over several years of doing this is that we get these partial truths and these partial hype, and then we stir this all in with a whole bunch of jargon to create kind of massive confusion in potential collaborators, right? They're not sure, it's all black boxy, they don't know what exactly they're getting into, and they don't know what the true impact is. We always, I think, particularly scientists, we want to look very sophisticated and knowledgeable, so we overcomplicate things, right? And so we don't call things small, medium, and large. We call them venti and grande and stuff like that. We have our own jargon to make ourselves look kind of special. It's kind of academician kind of an approach. And so I think the lessons that we've learned is really, if you want to try to impress people, you have these very complex solutions. But if you really want to have an impact, you should keep things simple. And the key thing here is simple is much harder than complex. Complex you can create, oh no. I lost my, thank you. Lost my ability to forward. Yeah, so simple is a challenge, and it takes a lot more time, right, to write something simple. Maybe you know Mark Twain, who famously wrote, sorry that I didn't have time to write a shorter letter. It's hard to write short, concise pieces and be specific. It's very easy to drone on and elaborate too much on stuff. So keep things simple is kind of the key thing. So I'll give you some ideas about what you might keep in mind to keep things simple. I think the key thing is to keep in mind what the goal is. I think that gets lost a lot of times. So the goal, I think, and particularly in healthcare delivery in particular, is creating value in the delivery of care. And so value kind of is a simple equation that is quality divided by costs. And in the US, there's been this development of a quadruple aim, where quality is broadly defined by improving the patient experience, improving clinician satisfaction, and improving care and quality, care quality and outcomes. And kind of embedded in that, they've added another thing to make a quintuple aim. Embedded in that is equity, right? Make sure that things are equitable and fair. And all of this is divided by the lowering the per capita costs of healthcare. And what I assert is that if you have a product that you're trying to, that's focused on healthcare delivery, that doesn't do at least one of these things, you don't have a product. It's not going to have impact on the population. It's not going to have any meaning, really. It's just going to kind of add to complexity. The challenge in healthcare, I think, which particularly in developed countries, is, there's a lot of technology in healthcare. It hasn't achieved any of the efficiencies that you've seen in other industries, like finance, right? Where we used to go, if you need a check cash, you would have to go, some of you maybe remember this, you would have to go to your bank and see a person, a teller, and you would have to write the check out, and they would give you money out of your account to get that. And now you can go anywhere in the world and plug, use any kind of card that you have and get the money that you need in the currency that you want if you're in that country. So things have really changed, and there are fewer tellers, and there need to be fewer tellers. In healthcare, particularly again in developed countries, the addition of things like electronic medical records has led to physician burnout, and this created a whole new area of labor which are called scribes. So scribes follow around doctors to take notes of what the doctor said so that they can enter it into the electronic medical record. And so that usually when you as an economist, when you add technology, the trade-off is you have less labor, right? This, you added technology and you added labor, which kind of doesn't make sense. So the key things are to think about these kind of areas, and lowering the per capita cost of care is probably through lowering some of the labor costs and making the providers much more efficient. The other thing to think about is what is the care process? And this is just kind of a little diagram that shows that people come in, they have a healthcare need, they're assigned, they get oriented to the practice, oriented to what you're going to do with them. There's an initial workup and a plan of care that's developed, and then they have a variety of different care options, from kind of normal to having some acute care process, chronic care, and palliative care if they're at the end of life perhaps. And then you have these patients at the end who have their needs met. And you can then think about kind of measuring what their functional outcomes, their biological outcomes, their satisfaction cost outcomes are for those different populations. So providers tend to have this process, countries tend to have this process that's kind of embedded in how people use the healthcare system. I think a lot of technological solutions say all you have to do is change your entire process. That's not going to happen. Doctors, they're very stressed, right? They spend a lot of time getting where they're going. They learn this process that they're in. You have to change you have to add technology in a way that basically helps them get home to their family faster at night, helps them process patients with less pain. So again, going back to that earlier slide, improving the provider experience is the only way that you're going to get technology adopted into an existing process, whatever that process is. I would also kind of consider, particularly since you're in the public health arena here, the relationship between individual and community or public health. And so from the individual, we can collect data, we can roll that up in a continuous learning process to understand what the community needs are and the community health status is. We can then continuously apply and invest into individuals, things that have been demonstrated to be helpful for the community and for individuals. And when we think about the things that could be helpful for the community, we can be thinking about these social determinants of health, the environment, housing, jobs, these kind of things. From the individual, we might be able to identify and articulate in kind of a precision medicine kind of a way what works where and for whom, and when and what type and where is the return on investment that comes to the community by investing in these particular areas, focusing on these particular treatment patterns for particular patient groups. I just want to think that you should also remember the importance of the social determinants of health. If we look at this little diagram here, socioeconomic, this all adds up to 100, and it's 100% of the health of an individual or of a population. So socioeconomic factors kind of contribute 40% to the health of the population. The physical environment is about 10%, health behaviors is about 30%, and healthcare itself is about 20%. So more and more, I think governments will figure out that it's a wiser investment to invest in those top things in socioeconomic and physical and kind of influencing health behaviors than it is in just adding more health care. We're very good, we should call it illness care, really. We're very good at illness care, where we treat illnesses once they arise. We're not so good at producing health. The top stuff is what produces health. That should be the focus of nations, and health and well-being it should be the focus of the nations and what the goals are of kind of any kind of a healthcare system. From an AI perspective and kind of tech perspective, those top things have been really difficult to capture at the patient level. You can get them at some kind of a geographic level. They tend to be old, 3 years old, based on survey data. And so by the time you're trying to intervene, the things already happened that you need to intervene on. Smart monitoring, I think, can help. If you can imagine everyone wears a watch, everyone's got a phone. You kind of prompt people with a particular question every once in a while, and you can get kind of ongoing, up-to-date survey data on the status of people regarding those top three. And the key thing about the bottom one is that patients, in reality, we think, if we're in healthcare, we think that they spend a lot of time in the healthcare system. Even someone who's really sick doesn't really encounter the healthcare system so much. They mostly are spending their time at home and trying to self-manage their chronic condition, maybe reliant on the community as well. So we need to kind of think about ways to access that information to drive better care provision and better outcomes for those people. Variation is something you should consider. Understanding and looking at variation provides a lot of insights, defines what the possible might be, and actually provide some very motivating visuals for people you're trying to influence. So here, for instance, is a map that we worked on in the U.S. You can look up the map at this aka.ms/health equity, where we're working. This is, for instance, life expectancy across like 3,000 counties in the United States. And there's a big, you kind of don't want to live in the southeast of the U.S. if you want to live a long life, right? And so you can see these very clear patterns, and you can do this in any country that you want. You can also kind of look at what the distribution of the population is. So most of the people who have better health are living in urban settings. There's kind of a relative overproportion of people in rural settings who have worse health, for instance, here. And you can indeed look across different groups. We grouped counties by economic distress, from the most prosperous counties to the most distressed, and you can see that that there's more people. The brown is lower life expectancy, so people living in distressed counties have a lower life expectancy than those living in prosperous counties. And research that I did found that actually, if the economic activity of the county, if the prosperity increases, so does the mortality rate actually decreases. So there's suggestions that you can intervene at a socioeconomic status level by economic investment to get a return on investment to health that accrues to the population that you invested in. You can also look over time. Here we're looking at 2015 and 2019 in blue, but in all but 2 states, Alaska and Hawaii, the longevity decreased during that time period in the United States. So people are living a shorter amount of time than they were, which has kind of never happened before. Here, this is work that we're doing, just thinking about the modeling. When we understand variation, we can look at variation, we can begin to understand it, understand the influences on it, and here's the potential of modeling in helping policymakers make more informed decisions about thinking about where they want to actually invest for the purposes of improving the health of the population. We have, for instance, the observed diabetes prevalence on the left, and then a predicted diabetes prevalence on the right. This is New York, and it's very, very accurate. So we can predict current and then into the future what the diabetes prevalence will be. If we can intervene on diabetes, we solve all sorts of downstream effects like hypertension and heart disease and kidney disease. And we can identify, based on the modeling, what are the relative features that should be intervened upon. And so here, physical inactivity is a big one. When there's high levels of physical inactivity, we want to we will see more diabetes. That might be a behavioral risk factor that can be intervened upon to improve the rates of diabetes, for instance, in New York. Oops. So I think another thing to kind of keep it potentially simple is to articulate the return on investment. And you guys all know what an investment timeline looks like. You have money going out at the beginning and you hope for money to come back over time. So there's a timeline. So this initial investment in something around your product or around the health of the population. And I think you need to be able to articulate the magnitude and the timing and who are the beneficiaries of the return on investment, because it's not always clear. And then the type of return on investment is important too, which we'll get to in a second. So when we think about the healthcare ecosystem members, right, providers and payers and pharmaceuticals and governments, policymakers and so forth, you can imagine that over time, returns on investment might accrue to them differently over time in different amounts, right? So the timing and the magnitude might differ across time for the different beneficiaries. And we need to think, when we think about the types of healthcare returns, we need to think about the healthcare returns and also the non-healthcare related returns, which would be important to potentially to governments, like economic growth. If people are spending less time sick and less time in the hospital, they might be more productive as workers, right? You might anticipate there would be economic growth. If they live longer, the buying cycle is going to continue for longer, right? They'll buy more stuff if they're alive than they would, say, if they were dead. buying kind of stops when you die. Political stability is better if people are healthy and have well-being as part of their agenda. And tax revenues will increase if people are employed and being productive and generating income that then gets taxed. So these are all kind of non-healthcare returns that might accrue to different interested parties on the left there. And so what we can do with the AI is to create simulation models for informed decision making so that policymakers, particularly politicians who sometimes have very short windows of interest, right? They're only for the next election cycle, which can be very short, to articulate for them when they might anticipate these returns to occur, to encourage them to make investments in the technology that you're trying to produce. The key thing is to identify who wins, when, and how much do they win. So the general then advice is to have simple, understandable solutions that can be integrated into current workflows, not create whole new ones, that have been demonstrated to measurably help improve the quadruple aim quickly and using controls. A lot of the pitches I see are people who have said, here's a before-after study and our technology worked, but there's not a control, so you don't know what's kind of happened to the general market. Solutions that address unwarranted variation and that identify the magnitude, timing, and beneficiaries of return to the initial investment. And the key thing is also they can easily scale. I mean, one of the great advantages of Microsoft is that we're in half of the world's population's houses, kind of, and the scalability is then gargantuan. Our challenge, frankly, in our AI for good efforts is to identify partners, because we work kind of with not-for-profits and with organizations that are fairly locally focused in how to scale these great projects that are like retinopathy of prematurity. How do you get that into the rest of the world to have true impact? And so there, I think there's got to be productization and partnership with for-profits to get the solutions kind of implemented and useful in the real in the real workflow of the real world. So the challenge and my hope, and I don't know what time it is because I have no more hands left. Okay, we got lots of time. So I'll just kind of wrap up kind of by saying the challenge and my hope. So this is our mission at Microsoft: to empower every person, every organization on the planet to achieve more. I think this can happen if people are healthier and have a sense of well-being. So our promotion of the AI for health and AI for good activities is to kind of consistent with our overall mission. And it kind of extends a longer-term mission that some of you in public health might be aware of. So we know that John Snow mapped the Broad Street cholera outbreak 160 years ago or so, almost 170 years ago, where this guy was the father of public health, right? He identified where, right, by just kind of measuring where people got cholera and relating that to the water pumps that were there on a map. He was able to identify, to avoid these water pumps and identify water pumps as a source of the disease that was killing a lot of people, right? That kind of started all of public health. And the idea is, again, to think about epidemiology and the way that, that diseases are transmitted in an effort to prevent them. It's a little tougher now with the diseases being chronic diseases like cardiovascular disease, but nonetheless, it can still be applicable to the modern problems of society with regard to health. From a geographic perspective, Emil Durkheim looked at variation in mental health disorders in 1897 and looked at, in France, different rates of alcoholic craziness and admissions for alcoholism. And I did a study that looked 150 years later or so at alcohol-related admissions, and it's not all that different. They're still kind of up in the northwest of France, a higher rate than in kind of the southwest of France and the southeast of France. The point of this is that traditions are hard to change. When I showed this to people when I did this work, when I was in France, I showed them, they say, oh yeah, those guys are all drunks up there. So there's, whether it's genetics, whether it's environment, social determinants, whatever, it's hard to change behaviors, particularly if they're kind of ingrained in the community. But nonetheless, understanding kind of the geographic variation can give you areas you would want to intervene for alcoholic problems up in certain areas and not perhaps as much in others. And then from an individual perspective, Ernest Codman started measuring patient-level outcomes in 1915. He worked at Brigham Hospital. He was a surgeon, and he began to keep these little cards of records of individual patients, the first guys to do this in healthcare. And he would see what happened to patients over time and then kind of collate those and actually learn from that as to this is this patient with this kind of characteristic. So this was the first AI was just a chart, right, on a piece of paper that would accumulate. And he got, when he started publishing this and started beating up on the Massachusetts Medical Society, he got into a lot of trouble and was kicked out of the society because he brought up, he kind of said, we're killing a lot of people, guys, and maybe we shouldn't do that so much. I don't think that's the business we're in. So nonetheless, he kind of founded the whole idea of quality improvement in healthcare, and now is kind of revered as an early adopter, early god for developing this kind of thing. The idea being that, again, collection of data, analysis of data in a consistent way can help improve the overall population outcomes that a particular hospital or particular area might have. And this is a picture, a painting by Gustav Klimt, who you may know. He was a Viennese artist. This is called Medicine. And he was hired by the University of Vienna to paint a mural on the ceiling, one of medicine and one of law. And so he worked over a number of years to develop these paintings. This is actually was lost in World War II. It was blown up. But the interesting thing that he did was, this is Hygeia, the goddess of hygiene, basically, in the front here. And there's some people, there's a naked kind of ideal body over here, but in the mass of the painting is actually death and destruction. Desolation is kind of hard to see probably from back there. Some desolation, some pain, people who are not doing well, they're neglected, they're poor, and they're vulnerable, they're pregnant, they're vulnerable people. So he painted this and showed it to the faculty at the University of Vienna, who repudiated him, got him kicked out of the arts school, and rejected the painting because everyone knows that around 1900 their assertion was that medicine had reached its pinnacle and had solved all these problems, right? Which we continue to have, 12 decades later. So they did the same thing he did. He was kind of aggressive with his perspective on justice and whether there was justice in the law school, and they did away with that one too. But these are the problems that persist and have always persisted in healthcare. The need to serve the vulnerable and to treat them in a way that's equitable and helps them address their healthcare issues. The hygiene is a big part of it. The basics, the kind of Maslow's foundations and all the stuff they talk about in the SDGs are part of getting that health right. But we need to continue to focus, I think, on the people who need it the most, who are the vulnerable populations, who are often in the lower and middle income countries. I think going forward, how AI can be kind of implemented to do that is it can massively speed implementation and reduce variation. So you think in healthcare, right, we're very science driven, and we can do all these papers, these randomized control trials, and show that something works and is quite effective at working. And then we implement it into clinical practice, right? And how long does that take? a mere 17 years, actually, is on average how long it takes to get stuff into medical practice from kind of definitive, this absolutely works, there's no debate about it, to have it work. And when it is implemented in clinical practice, we see there's a huge variation in the way it's implemented in medical practice. So this is just an example of breast cancer screening in women aged in their 60s, and it shows that this is just the rate of people it's been demonstrated they should get the screening every 2 years. This is the rate of women who actually do get the screening every 2 years, and it varies from about 30 to 90%, with a mean being 60%. So, 20 years after this has been demonstrably proven, about half the people are getting it. In the US, which is a very sophisticated healthcare system, right, where we can track all this stuff. I think AI can help by massively using the large language models, reduce the implementation into clinical practice from knowledge, right? So now we can use, instead of waiting for, I went to med school in the 80s, my guess is things have changed a bit since then, but instead of kind of waiting to retrain someone like me, keep me up to date on what's happening all the time, embed it into my workflow so that I am doing the next best thing right all the time based on the latest information. So I think that it'll go from 17 years to months, which would be tremendous and have tremendous impact on the population. I think when that happens with reminder systems and so forth, and kind of checks, we might be able to get that mean from 60 to more like 90% of the population that's eligible for it, and much less variation than you currently see. So it'll be quicker implementation of what's known to work to a population in a much more effective and efficient way. That should have a big impact on health of the population. AI can be used to help enhance cross-system learning. So here, for instance, these lines are individual providers in 3 different hospitals, and it shows their in-hospital mortality rate, risk-adjusted. And you can see that Hospital A there has a higher risk-adjusted mortality rate than Hospital B, is higher than Hospital C. So Hospital A has double the mortality rate of Hospital C. You can see there's still variation within the providers within those hospitals. Some in Hospital A do pretty well. Most of them in Hospital C do pretty well. What artificial intelligence can do is can help focus on how to help those who and train those within a system by identifying the people who are doing the best performance and sharing the knowledge of what they do with the people who are the worst performance. So within a health system, it can do that. Across health systems, you can imagine this would be quite effective at training and pushing down that mortality rate for everyone. So it kind of enhances kind of the continuous quality improvement learning cycle that has been adopted in healthcare, but might be much more efficient in identifying the specific things that the physician on the far left there is not doing right, that can be learned from the physician on the far right, and kind of raise all boats. That's one approach, is to learn and raise all boats. The other approach is just to get rid of all these doctors on the left. That's not going to be very effective. You're going to have even worse healthcare workforce shortage. I don't think, if you go to someone and you get poor quality care, that's not going to be useful, right? That what we need to do is much more efficient to retrain those folks, help them do the next best thing, keep them in the workforce so that you do have access to care, but access to quality care, not just any care. I think AI can help inform diagnosis. So here, this is supposed to do like this. So it shows if you see your physician over, every year or so, over a number of years, they may be monitoring you on something like your memory, and so they can see there's some variation that you see. But it's hard as a provider to keep up to this. You have 2,000 patients you see, and you see this guy every year. It's going to be tough to tell what the trend is, so but they may map it over time, and you might say, oh, here's some symptoms in year 4, and so we can identify that there's where maybe we kind of looked at year 5, maybe maybe he's not doing so bad, and do we really intervene? Better is to use continuous monitoring. Again, most patients don't spend a lot of time in the healthcare system. They do spend a lot of time on their phones and with their watches. We can monitor people's healthcare, monitor their health over time, identify when the functional range changes, where there's more variation, which might indicate more likelihood of disease, and then thinking about where to intervene earlier, to have earlier detection and earlier treatment, to again get patients more on the road to health than has been the past. So I'll wrap up by saying that, I try to cover like 150 or 160 years of time where there's been innovation in healthcare. It's been a long time. We've always had a similar goal of trying to help the vulnerable, help improve health. And along the way, we've picked up a lot of things that have been helpful in doing that, like, anesthesia. Has been a helpful thing for people who have ever had surgery. Antibiotics are quite useful things and have helped tremendously. Social determinants kind of stuff, sewer systems have probably done more than anything to promote health. And now we have vaccines that are quite effective in helping to prevent unneeded bad outcomes. So it's been a long road. We've got a bunch of medical tools. We finally, I think, have the data tools, the infrastructure and the data and the compute power to solve these problems in a way that maintains a provider workforce, that uses the workforce much more efficiently, and that helps identify and focus on improving the health of the population. We have to focus on this quadruple aim when we think about healthcare delivery and reducing waste. Every time we waste money by overdoing tests, by providing unnecessary treatments, we're it is a win-loss kind of a world. We're taking away resources from someone who might have better used it. So we need to think about eliminating waste in order to better promote the overall health of the population. And when you do an unnecessary procedure on a patient, you expose them to unnecessary risk. And those risks are real. We know, for instance, in the US, that 100,000 people a year die of medical errors, including overdiagnosis and unnecessary treatments. So we can maybe improve the health of the population by not doing as much, by doing the right things for the right patients at the right time. We need to objectively measure and analyze the interventions that we use, particularly when AI is one of them. I think one of the problems with AI is people, they'll do a test and they'll say, hey, this works, and then let's apply this to the entire world. It needs to be reanalyzed and reassessed on different populations, right? Because different populations may have different responses to whatever the algorithm is that's being implemented. And I think this work is very complex, right? And the only way to make progress is to have these coalitions of self-interested parties from multiple sectors, so public-private collaboration with governments to help focus from these different angles, bringing their different tools together on the improvement of health of the population. And I think that's it. Thanks.
Wow, Bill, that was, I have not heard this before from you, so I'm stoked. This was amazing. Did you like it, guys?
Yeah.
Wow. I'm sure we have probably tons of questions, but the first question coming to mind to you is, obviously we know there is a lot of, unfortunately, inequity when it comes to building strong models in the space of artificial intelligence. What can African health and technology startups do to help decrease the level of inequity in AI?
Within Africa or across the world?
Across the world.
Yeah, so do it. It's Africa that needs this the most, perhaps, right? I think you do it internally, you do it from within Africa, looking at patients who are living in Africa, and not just take an algorithm that's based on people who look a lot like me and not so much like the African population that might be available from the US. Test this stuff, make sure that you're engaging the ministries of health in your analytics and thinking about the way that the analytics are actually implemented and who it will impact, and make it a homegrown solution, frankly, because just exporting from the more developed world is not going to be the right population. Will have biases inherent in the algorithms.
I have another question, and then I take it over towards the audience. But we often talk about building these population health models, innovating on a large scale, on a city, region, country, continent. It does sound kind of easy, but actually it's not when you're dealing with a lot of different data coming from a lot of different places, even if you want to do good. So what role can organizations such as your team within Microsoft, but also this community here, what role can all of us play into, I guess, improve the data sharing for good?
Yeah, so lobby for it. I mean, I don't know what else to say. It's got to be open data. Without the open data, this stuff just isn't going to work, right? You're going to have very select groups of people who get, who are in the algorithms. These data, we're terrified of. It's really not clear to me why, because our financial data are widely available to anyone who's got $50 who can buy a roster of everyone's FICO scores in the room for nothing. We worry a lot about health data. The data can be anonymized, can be protected. If it's on a cloud, it's very, very safe. You can analyze it using federated computing, for instance, in a way that protects the rights and the identities of the people who are being analyzed. There's all sorts of ways to do this. We just need to kind of do it. Vodon is a great example of trying to work across multiple countries in Africa to standardize the data in a way that you can use federated learning to learn about what's happening with instance with regard to HIV treatment adherence in an effort to intervene and to learn from one another about what works and what doesn't, without compromising individual security. So there are ways around this. The challenge to me, frankly, is that there's a lot of hospitals in healthcare systems that want to maintain their information on premises, right? It's much more at risk there. The data are much more at risk. Hackers come in. It's all, places like Microsoft and AWS and Google, they have these cloud-based solutions that we have teams of anti-hackers working on this constantly, trying to beat the hackers at their own game pretty effectively. It's kind of, I think you need to promote safety in the in where the data are held and how they're secured, and also liberating the data in a safe way that respects individuals so that the data can be used for the good of the population. If everyone just says, you can't have my data because it's mine, I think it would be very challenging to improve.
Questions? This is, oh my God, there it comes. Let's start from the second row.
Hi, my name is Faye. I'm founder of Cloud Equipment. It's a startup based in Nigeria with a focus on medical devices as a service. I had a question around your solution that kind of used radiology, learnings from ultrasound machines in place of MRIs. Could you speak a little bit about that and what kind of ideas did you have around that? I think that would be my question.
Yeah, so it's early. We're a research organization, and the definition of research is that you don't know what you're doing, and you expect to fail a lot in research. It's very different from product placement, right? You expect to fail when you do these things. So it's a new project that we're working with the University of British Columbia on, is trying to take ultrasounds and then create kind of from a 3D into two-dimensional MRI equivalent quality stuff. We're making progress on it. It's a challenge, right? I think Philips can do this faster than our group of 35, probably.
So the reason, is there somewhere we can look at the research, like a link or something? The reason why I'm asking is we started by financing mostly laboratory and radiology equipment, and we're going across several, really small scale hospitals. So there might be an opportunity to kind of look at what that data looks like and how we can potentially, tap into the power of AI for this.
Just shoot me an email. I'll introduce you to the guy. Yep.
See how
I think
problems are
that
solved, right? I mean,
immediately,
on the stage.
But I mean, the beauty of this is that ultrasound, as you know, right? Ultrasounds are portable and cheap, and you're not going to be able to put an MRI in, in every county in Kenya, for instance, right? You're just not going to be able to do it. So, and they're reusable. You can send them in the mail. You can reuse them. So, there's a lot of potential, I think, in that.
First question. Present yourself.
Thank you. Hi, I'm DG, a fellow physician like you.
Yeah.
But working. Can you hear me?
Yeah.
No. I'll have your mic then. So I'm Niti Paul. I'm a physician like you, working in global health for many, many years. Today I represent the payer. So I work with AXA quite a lot as an insurer, but I've worked in public payer systems. So my question around is the funding of this. So any use cases that you have around, say, for example, your retinal example was a good one. Who's paying? And a lot of times when it's replacing physicians or someone else, somebody will pipe up and say, but somebody didn't see the patient, so you can't be paid for it. And I know that in systems like America, that's quite a problem. In public systems like mine, where I come from, the UK, it's less of a problem. Yeah. But lots of low and middle income countries face the same. So that's the question. You talked about payment and you talked about, how do you do this? And just following on from that, on money, is quite a lot of these solutions are very expensive for the countries that I work in, with Lucy and others. And it's really hard to then put it in place. I work with the inclusive insurance arm of AXA, and it's really difficult to find the solutions that are $1, because our insurance premiums are $1, $2. And to get something that actually works for that is really hard.
So that's the reason I would do that ROI analysis and understand who wins where. So I think with the ROP, with the retinopathy of prematurity, it's really the governments that are going to win there, right? Because they will not have kids on disability for 50 years because they're blind, right? So I think you have to appeal to their, I got an MBA to learn the dark side, and money drives everything, right? And so you have to appeal to what's going to save them money, right? For an AXA, if you can avoid unnecessary hospitalizations, unnecessary surgery, stuff that they're paying for, that is eating away that $1, any profit margin that's on the $1 thing, not much, right? Then that's going to be of interest to them, and they might invest. Particularly, though, I think if you do it like I suggested, where you say, here's what accrues to which group when, you can create interesting coalitions. So maybe it isn't necessarily just funded by AXA. Maybe it's funded by AXA because they win some, but the government wins a lot too. So we have these coalitions again coming together. Maybe it's Novartis that wins because they have a bigger, not the foundation, but they have a bigger group of pharma market. So I think you just have to do that kind of rigorous financial analysis to figure out who the potential partners are, and then go to them with that and try to build a coalition, because it depends entirely on what you're doing, I think.
So I just want to piggyback on what you're saying, because right before the start of our Investor Summit, we were leaving a fantastic workshop organized by our partners, the Global Fund. One of our key topics there was exactly on sustainable business models, and how is financing being essentially sliced and distributed, looking at who are the different partners in the value chain. Because you as a startup or as a scale-up, you're not going to work with the same people at different moments of time, and you're not going to be able to solve it all by yourself. So that's one of the beauties of the HealthTech of Africa, that brings together the ecosystem of partners, both from the public side of the system, but also the private side of the system, like Bill, you're saying, to find who can finance what at what kind of time and what kind of, let's say, duration and size. And is it all about financing, or it's sometimes about core resources and assets that you can put on the table? So more on that in the next days. Other questions? We have time for a couple of more. Please present yourself.
Thanks for the presentation. It was very informative. My name is Shiva. I'm the founder of Digital Realm. We're basically an interactive entertainment and immersive technologies company. And on the side where we come for the health tech is through our cross-sector innovation strategy, where we try to use game technologies to impact and innovate in other sectors. And we've been actually blessed to work with Microsoft. And part of the Microsoft ecosystem, of course, we use Azure, and we've been building our high-play-layered AI engine to actually bridge the sector for enhancing the user experience for the healthcare. But when we try to build a model to actually serve our African users, we realize that those large language models, they lack essence in data set that is used to train them that actually address the African users. So which means we need to deconstruct those models, and those are big and they're expensive to build. So what is your strategy to actually work with African entrepreneurs and innovators to actually solve that? Thank you.
My strategy is, so we're a very small group. I think Microsoft probably has a strategy to do that, where they should frankly help fund that kind of thing, right? As Lucy pointed out, and we've done research, right? The African continent is kind of the only population growth center in the world for the next 30 years, right?
So we already use Azure?
Yeah.
We already use Azure, and we have access to all of the intricacies in terms of like OpenAI's database of earlier models that they use to build all of their GPTs until to the latest one, the 4 version, and we have no issue with Azure credit. But when it comes to build those models, all of these matrix operations to actually build a model on the scale of ChatGPT or GPT-4 using our own data sets, it's actually very, very resource intensive to the scale that goes beyond what an African startup that is early stage can be able to build. So even though we have the support of Microsoft in terms of resources and capacity and capabilities, so it's still like a huge gap to be able to bridge it.
I appreciate that, but I think Microsoft has big other resources beyond our small group, right? With tech innovation as part of that. So I would think them or the OpenAI folks who we partner with would be the group that would help you do that analysis, right? Because we can provide the GPUs, right? The beyond just the Azure. That's okay. You want the actual physical help of people to.
So technically, it's more on the side where you have healthcare practitioners, because we want to improve the experience of the healthcare users.
Yeah.
But then we have to work with a lot of healthcare practitioners, which means access to all of that data. Even if you have access to the data, sometimes you realize that the capacity required in terms of maybe human capital, in terms of skills, we don't actually scale to that actual level of quality to be able to deploy that solution and solve the problems that we have. And if we use the existing solutions by like forking them, we realize that we lack in terms of data sets and actual quality results. You know, AIs, they hallucinate, they make up stuff.
Right.
So you need to have the right data.
Yeah.
So
No, absolutely. And I think getting the right data is critical, and that's part of what we look at. And I think Africa has, I mean, the groups we work with in Africa have had challenges in getting accurate, good data, right?
But I also have good news. So Africa CDC, which also has a larger summit this week, has different flagships looking around data and interoperability. We're working on it, also influencing some of the direction of this discussion. There is the need of what we call a regulatory sandbox for Africa, which sets kind of the precedent of, okay, where is this data coming from? How can we create process whenever we're talking about testing within a regulatory context? How can we get access to more data? What are the process and all that? But that would take a little bit of time, and more partners, such as, you know, our partners from IQVIA in the room as well, and Microsoft, the philanthropies, and more people around the table to not only collect the data, but then bring it to the same standard and place, ideally, under the good privacy conditions for people. Last question. last two questions, very short. Please present yourself and...
My name is Jean-Claude de Carasila. I came here for Watoto coding from Kenya. So what we do, we help students like 6 to 12 children, 6 years old to 12, to learn how to code in a very simple way using the iPads and other stuffs. So my question was, you mentioned that Mr. Williams said that they are using satellite and imaging data to identify post-disaster zone. So I wonder why you use with those data, because it's like after the disaster has took place, and I want to ask if there are any other ways how the African governments are working with you, like that the disaster struck Syria, and then afterward it struck Morocco, and so I just want to know if there are any other ways that you cooperate with those governments.
Yeah, absolutely. We work on disasters of any ilk, indeed. And I mean, one really intriguing kind of problem is thinking about what is the type of disaster, right? So if you think about like houses and identifying houses and the types of houses that there are, and you can look actually close enough to identify the type of roofing there is, that gives an indication of what the structure of the house is. And then you can look at proximity to rivers and mountains and things like that. You can anticipate the impact on a particular type of disaster. So a flood will have a different impact than an earthquake or a mountain slide or a glacial dam that breaks and floods from above, right? Those are all, the cool thing about AI is that you can do models for all of those. And we do that worldwide with our partner Planet. So including Morocco, we're working with someone in WHO, I can't recall who, but on kind of anticipating flooding, right, or drought, and with the drought more on the impact on famine and things like that. But for more like immediate disaster responses, I'm thinking about flooding, right, and modeling expansion of rivers and what that would do to communities next to those rivers, based on the type of housing that is in that community. And the distribution of that.
Thank you, Bill. Last, very short question. Please present yourself.
Thank you. My name is Jackie Ngaruki. I'm the country director of Ejo Twifuza organization. And I'm a PhD candidate in health economics, but specialized in health investment and economic growth. My question is how civil society and local organizations works with Microsoft to use data to create systems that can help them participate in managing data and using these data for improving life of new generations.
Yeah, so generally with our group, we work with a large organization like PATH or BRAC or Vodon or some other group that is already established and has relationships with the community, because they then have the level of data and can have kind of a broader impact. But if there are some not-for-profits that you know of that are in a community and you want to contact me about, is this a potential kind of area where we could do a project, that would be something we would be open to examining. Okay.
Oh, wow. Round of applause for Bill. Thank you so much, Bill. So, an obvious conclusion, around the world, technology is slightly faster than the speed of innovation in policy making, right? So what can we do about it? I guess you're going to hear some good ideas from the co-founder and CEO of HealthTech, Adrian. Please join us on stage.
Thank you. Hi, everyone. Here's my clicker. So, hi Lucy, and thank you for the invite. And the people, I must say, this facility is amazing. I walked around a little bit earlier. I've been to many places. I've not seen a place like this. It's really, really cool. It's an amazing place for startups to do your thing. Yeah, I think my session today, and obviously also thank you to Norsken and all the other partners and the people who helped me with my presentation and all the emails and stuff. I think my presentation today is a little bit different. So I'm going to share our story, and we were also a startup. Sometimes I hope we were still a startup, because as you get bigger, you get more HR issues because you have more people and all of that. But we're still small. We're only about 40 people. But I thought I'll maybe share my journey and our journey of where we've come from, and then through it all, because I know a lot of you, there's so many different types of people in the audience today, from medical device companies and software vendors and people coming up with all kinds of interesting things and funders. And I thought I'll present something that's applicable to all of you. So yeah, my name is Adrian. I started this company. I don't know. Let me just see what this first slide is. So so yeah, the company is called HealthTech, and it's literally with a Q at the end because HealthTech ending with a ch.com was taken. So we made it with a Q. You know, our startups, we like our domains. So the big thing for us is I have a technology background. So after I studied computer science, and I worked with Oracle products and for Oracle for many years. And then I had a good friend of mine who studied medical sciences, and he actually wanted to qualify to become a doctor, and then he started working at a contract research organization. For those of you who don't know what that is, it is a CRO. So those are organizations. There's two logos of companies like that. IQVIA. I was here in Rwanda for the first time last week, and then I arrived again this morning for the second time. But IQVIA is a really great CRO. So big pharma companies, big biotechs, they go to these companies and they outsource their clinical development work to them to help them go through all the clinical trials and ultimately register their product. So long story short, when we started the company, we realized that a lot of the research that is being done in South Africa or in Africa as a whole is being done on paper, because the solutions that do exist that digitize the role of clinical trials, they are there, but they're very expensive. These vendors are based out of the US, based out of Europe. So we set on this journey to become the first company to have a fully FDA validated and EMA, the European Medicines Agency validated solution that people can use to run clinical trials with. It was an interesting journey. But yeah, today we've managed to succeed in that sort of original goal, and we've done a couple of other things. So you'll see now, I'll share a bit about the good, the bad, and the ugly. But yeah, working in this highly regulated world for a technologist and for someone who likes innovation is difficult, because there's red tape and you have to document everything, and you can't innovate. Like, our developers write code faster than our quality assurance team can document everything that they're doing. So it's interesting. But yeah, I think we're quite lucky. I think about 6 years ago, we started the company about 9 years ago, and about 6 years ago, we got introduced into the public health space, because you meet all kinds of interesting people once you start doing research. So today we're very, very fortunate to do a lot of work with the Bill and Melinda Gates Foundation, where we're one of their technology partners in Africa, helping with a number of different things. I'll tell you a little bit about that later. And then the EDCTP is the European Development Clinical Trial Partnership, a very amazing philanthropic group where they get funding from a number of different sources on an annual basis. And they literally, between 100 and 200 million euros, they pump into Africa on an annual basis to help with capacity building and everything around clinical trials. And I think our main goal in about 5 years is to see if we can make a big impact in other low and middle income countries. So we are dabbling a little bit in South America. We have a nice footprint in India. And who knows, maybe even take on some of our big competitors, being Oracle or being IBM, maybe in the US one day, who knows. So yes, I'm just going to run through a couple of the things that we do, and then I'll tell you our journey. So it's small, the text, I'll talk through to some of them, and these slides will be available. So we're a technology company, so we build web-based platforms. That's what we do. We don't have medical devices, although we've worked with it many times. So we have these different platforms that help companies run clinical trials, or also in the primary healthcare space. So these are different web-based platforms that you can set up. All of our platforms are no-code or low-code platforms, so everything is configurable through the front end. You don't have to have a developer or an analyst or a database administrator to configure the forms and the edit checks and everything. In the back end, you have one user on the front end, and they set up the whole structure of the clinical trial through the front end. And these are different types of platforms that is used in different phases or different parts of a clinical trial. And then the two solutions there at the bottom, those are more sort of traditional workflow programs that a lot of these biotechs need to manage their internal processes. So with both of those, highly regulated, deal with patient data, lots of red tape. So I'll tell you about that. Then on the public and the private health side, so here's where we got involved into digitizing some of the regulatory processes. So obviously before you can buy a product in a pharmacy, or you can use a medical device or buy a medical device, it has to go through a stringent process of being registered. And before you can start that process, you need to get, in most cases, ethics approval from different ethics committees. So there we built a digital platform for ethics committees, because all ethics committees in Africa run on paper, and now it's a lot better. So we've got, of the 220 odd committees in Africa, at least 25 of them is using this platform that we built for one of our non-profit partners. And then I think I'll just talk about the second last one, the clinical trials community platform. Bill, that's where we also use a bit of large language modeling, a bit of AI, or more machine learning. So that platform is, you can go there today if you are interested in clinical trials at all, ctc.africa. It is well funded by both the Gates Foundation and the EDCTP. It is becoming the platform that the Africa CDC will adopt in the coming months. They will be the owners of the platform, and there we've literally taken data from a number of different public sources, and we have mapped all the research centers on the African continent with GPS coordinates. All the data that we are getting from a number of public data sources are dirty, very dirty. So we've built our own model to clean the data and implement the data standard so that we can accurately map them, and then we can see all the trials. I think on our system we have about 20,000 clinical trials that have been registered over the past 30 years, and then we automatically, on an ongoing basis, we map them against these facilities. So if a sponsor or a pharmaceutical company wants to do a trial, they can come to this platform and they can see who are the right people that they can work with, that has experience. The last one there is Intercare. This is our first journey into more the primary healthcare world. And this is also how we could potentially help you open some doors to commercialize your products. So Intercare is a group based out of South Africa. We are their technology partner. They appoint about 250 doctors and about 100 dentists. They have an electronic health records database of about 1.3 million patients, and they have active patients of about 800,000. So on our online platform that we've built for them, they have regular interactions with about 100,000 of them on a monthly basis, telemedicine, visits, online bookings, different things like that. And they are very forward-thinking. So that's one of the areas that we could potentially help you open a door, or at least explore it. So the good and the bad and the ugly. So the good, I think, on our side, I said in my next life, maybe we will work in a total different industry. Maybe we should build rockets that goes to space, because maybe it will be less regulated, or maybe, I don't know, we should, I'm trying to think of examples, but I'm struggling now. But I think the good is, it is definitely you're making a positive impact in humanity. There's the solutions. We're not literally there where we have an AI device that can help detect a specific disease, but at least we're part of the whole life cycle. And if a malaria vaccine is ultimately administered in 2031, but in 2023 they used our software to run the tests, we were part of that positive impact. So all of our team members, we like that. I think as part of this journey, we've been very fortunate to meet inspirational people. That's the cool thing about working in the health industry. So that's also something good for us. And we get to travel. All of you'll know, and some of you will definitely get to travel a lot. You see this beautiful continent of ours. It's you meet amazing people. I've been to interesting places on this continent. Kigali is my top 3 city I've ever been to. It's amazing. It's really, really cool. So the bad, we struggle, but I'm talking here as a used to be startup person. I'm a serial entrepreneur, so I love starting businesses. But the bad for us is our end user. So working, no offense, sorry to the people in the front, but doctors are difficult to work with. So difficult. So it's so we have to constantly, because exactly what Bill said, you have to make it so intuitive. You must help the doctor still not deliver the same quality of care to his or her patients, but you must enable him or her to get to his family 30 minutes sooner. That is a challenge in itself. How do you do that? So it's been an interesting road. I think that is one of the bad things. The other bad thing, but it's a necessity, is it's highly regulated. So it sort of slows your speed of innovation working in this industry, because you have to really make sure, specifically if you're in the diagnostic space or medical device, or us working in the clinical trial space, you have to document everything, and you have to triple test everything, and you have to sit through audits, but it's part of it. And so the big thing that we saw is you'll never be perfect, especially if you operate in the clinical research space, but just keep on improving. Then I think the ugly are these audits. So we are quite prone to audits, and if you are, I don't know all the startups, but I'm getting to know some of the names. I'll get to know you guys in the coming days. But any software where you deal with medical data, where you deal with medical devices that needs to be registered, there will most likely be an audit coming your way from a regulatory agency. Those are tough. It's very tough, but it is there for a reason. So there's a couple of, it's coming into this, how do you navigate the regulatory space? So there's a couple of links, and afterwards I'll share all of this, so I'm sure the organizers will share all these slides. There's more links at the end as well. But there's a couple of nice ones to really get you going, to understand what you're in for. And we also, that's one of our key things when we partnered up with the HealthTech Hub, is to offer our services, offer our software to help you guys on your journey. If you need any help, we will offer our software at cost price, and we will offer our time to help you on your journey. So an SOPs is a standard operating procedure, very, very important to have those things as a company. And we just saw, we learned the hard way, it's actually a lot better to just write those SOPs yourself instead of copying and pasting them from the web from similar companies to you, because you're just going to have lots of interesting findings in an audit. But we'll happily share those journeys with you. So I don't know how familiar you guys are with the whole world of clinical trials. Like, how do you literally register a compound or a formulation, and how do you ultimately get it into a pharmacy? So this is a 2-minute crash course. So the figure that you see there on the top left-hand side, so those are the pharma companies, the biotechs, the people, white lab coats. They are very smart pharmacologists, and they are thinking and coming up with new formulations, and I'm not a doctor, so I'm going to not say too much there. But if they see something that works, they register a patent, and that patent lasts for 20 years. Okay, so their goal is, from that day that they register that patent, they need to get it into a pharmacy and sell it, because to get it into a pharmacy costs many, many millions of dollars. So then they need to sell it so that they can return on investment, back to Bill's point earlier. So they can either do it themselves, so this middle block is sort of all the things that they have to do, specific things that they have to go through to ultimately get their product on the market, or they outsource these things because it is a very, like a speciality thing that you have to really understand. So that's where contract research organizations were born about 45, 50 years ago, I would guess. And ultimately it goes through this process. I'll tell you now about the different phases that it goes through. And then right at the end, through each phase, it goes to the regulator. And then they say, okay, the tests look good. Please increase your sample size or change your patient populations. I'll tell you now how the phases work. And then ultimately, it gets through the process and you can start it in a pharmacy. Nowadays, if I have to tell you, give you a scary fact, out of 10,000 compounds that are new chemical entities that are patented, only one gets to the pharmacy. So the cost of all of those people trying to get a drug or a medical device, not really a medical device, a new drug on the market, costs roughly $1.3 billion. And only one gets to the end. So that is why, yes, it is a process. But I think with AI, we can really move that number down, and then the drugs become cheaper in the end. So there's lots of things going on in that space. Here's the different phases of a clinical trial, so you can read this yourself. So on the left-hand side are sort of the different processes that is performed during a clinical trial. But in the first phase of a trial is where you test a specific drug on a healthy volunteer. Often with medical devices is also the similar process that you have to go through. So those are typically males between the ages of 18 and 25 that are healthy, and they is just tested there for to make sure that the drug is safe. And then as you go with all of these phases, there's lots of documentation, lots of things you have to go through. But we obviously, once again, more than happy to help you with all of those things. And then once it goes through phase 1, then it goes to phase 2, then it goes to phase 3. So phase 1 takes roughly, let's say, 12 months. A phase 2 trial takes 2 to 3 years, and a phase 3 trial takes 3 to 7 years. And then there's lots of paperwork and waiting and all kinds of things happening. I saw this is what happened with you earlier. Okay, so as part of all of this, sorry, I have to go through some of these boring steps, but it is very, very important. So if you have a software platform, or if you build software that is at all, you're thinking of using it in the regulated space, or you want to register a specific medical device. So in our case, because we use our software in clinical trials, this is the model that we used to validate our software, and it's like an ongoing thing. It's really well documented. It's a GAMP5, sort of the V model. So on the left-hand side is how you specify all the different parts of your product, and on the right-hand side there's like a correlating test that you do from a granular level all the way up to like user journey test or end-to-end testing. Really documented in depth. So one of our platforms, to give you an idea, our main platform, it probably has documentation of about 3,000 pages for one version. And with obviously with a medical device, it will be a lot less. And if it's not a complex system, it will be a lot less. But this is a very important thing if you want to dabble into the regulated space. And there's one of the links that I shared earlier explains all of this very, very nicely. So OFNI Systems is a great tool to look. And then also you can go and Google GAMP5. There's lots of and different ways of how you can document and validate your software. With medical devices, I know a lot of you are in the medical device space. There's lots of regulations. It's much easier with a medical device to get it on the market than a drug. So obviously, I'm from South Africa, so I've shared some details of the South African regulations. There's a couple of great links in here. I think this second link here, it explains all the questions that you might have around a medical device, how do you register it in a country. SAPRA is also, they lead the way when it comes to regulatory agencies. So they guide a lot of the other countries. And when it comes to these things, they're also very active in the African Union and NAPAD, setting up the African guidelines. So if you do follow their regulatory guidelines, it would most likely be applicable in Rwanda or Uganda or Nigeria. But once again, I'm happy to go into detail and chat to you in the coming days or in a follow-up call, and we can help figure it out if you want to get a medical device registered in a specific country. Okay, so this is what I've been saying all along. So it's sort of a clinical trial. This is what I said. It takes like 8 to 12 years to ultimately get your product on the market. But if you need help in any of these phases, you're more than happy to reach out to us. So it is quite complex. In the beginning, the most important thing is you have to design your study in a lot of detail. And during that study design, you have to work with a team of biostatisticians or a statistician to make sure that whatever you're doing, ultimately it will be worth it so that you can prove your point and there's enough power, or all those fancy words that the smart people use. There's a lot of regulatory processes you have to have help to putting together your regulatory application. But all of those things, if any of you need help with that, we'll be more than happy to assist you with that. So me being also a startup person, ultimately for me, it's about how do you make money? How do you make your business a success? So I know when I spoke to Lucy, one of the things that we'll try and do is open doors for you if you get to a place where you want to commercialize your product. So this is the Intercare group that I mentioned. They have a nice footprint. Mediclinic is one of the big hospital groups. I think one of probably the biggest private care hospital groups in Africa. So Mediclinic, they own a significant portion of Intercare, so we know the people there very well. So if any of you are close to where you want to commercialize your product, happy for you to reach out to us, and we can sort of maybe set up a presentation or a pitch session with them. Zebra Medical is a company that we know that help. They are distributors of medical devices, specifically in South Africa now. So it's also something that we can introduce you to them. And Pharmovs here at the bottom left, they have been running clinical trials to get medical devices registered and products registered for about 50 years. They've done more than 3,000 trials. They've undergone many audits by the FDA and the European Medicines Agency. Also, we are their tech partners, so we can definitely help you get you there. This is, I think, my last slide because there might be some questions. These are just tools that we found over the past 8 years that has really helped us, and these things might be really valuable to you guys as startups. So one of the first things is often around training. So people need to understand how your software works or how your device works or how your algorithm works. So loom.com is a fantastic tool that you can use. It costs $10 a month. And there you can make very nice interactive videos and that you can share with your potential customers for them to see exactly how your solution works. The second one, there is Elements. It is a product by Invato. You can Google it. I'll also, happy for you, I should have put that link there. But there, if you need PowerPoint templates, if you need a business plan template, if you need stock videos, if you need stock photos, anything like that, that is a fantastic resource. I think it also costs $150 a year. It's a really affordable solution, and there you will have almost all your potential design elements that you'll need. And you can download it as many as you want, and then you can build nice presentations, build a nice website, whatever you want. The other one, the third one there is called Articulate. So it is a fantastic tool that helps you create online training content, but in HTML5 format. So it is like a interactive PowerPoint presentation where there's animations, but it's in HTML, so it can be housed on a web interface. It's super easy, and it is very, very impactful. You can literally take a PDF document full of text, 2 pages. It takes you 1 hour, you turn it into an Articulate 360 training file, SCORM file, and the uptake is like, the improvement is 500%. Really, really nice. Once again, so you can see the first and the third elements really around training. That has really helped us a lot. The fourth one there is something we discovered. It is, sorry, I'm going to say fantastic, cool, and nice a lot of times. Sorry, I'll stop. But the fourth one is a chatbot builder. It is, once again, $10 a month. It allows you, with a no-code, low-code way, click, drag, drop, build chatbots. So you can build it in WhatsApp, or you can build it in a web chatbot. So we use it. You can go to hello.nuvotech.io with your mobile phones, but that's we use it as an information bot. So you can click around and it feels like someone's chatting back to you, but you can add a lot of things into it. You can make it an e-commerce store. You can do a transaction. You can make it a recruitment bot that people sign up and they join your recruitment list. You can use it as your help desk element, where if anyone gets stuck anywhere in your software, they can use the chatbot. Really, really, really nice. Also, you can see all of these things. We're from South Africa. $1 is a lot of money for us, so we every cent counts. All of these are very, very affordable. The second last one is teamwork. So it's just to manage all of our projects and our Kanban boards. So those of you in the startup world, you know how these sprints and Kanban boards and swim lanes work. We use Jira. We first used Asana. It was a great product. Because it became a little bit too expensive for us. Then we moved over to Jira, which is a product from Atlassian. And we did a thorough investigation, and we recently moved over to Teamwork. It is really, really nice. It is everything in one. So there's your CRM and your help desk, and ultimately to run just your normal tasks as part of your product development team in one. Really nice. And the last one is Figma. I'm sure you guys know Figma. If you don't know Figma, it is the best way for your product team to design the screens that you give to your development team. So it's like a prototyping tool. They've got an add-on feature in there called FigJam that your business analysts can use. Once again, really well priced. And then I thought it's great resources. You have to share a couple of books. I love books. I'm not a great reader, but I'm a fantastic listener. So I do Audible, and these 4, I think, are the books that have really meant the most to me. I like when there's actual examples of how other people have done it. So Exponential Organizations, really, really nice. Lean Startup is a very well-known one. If you just follow what Eric says in there, you'll go a long way. You'll not waste money. I love AI Superpowers. It is scary what that book tells you, because it's how China are using AI. They are coming from a different place, more communist driven. So what Bill will tell you, the best way to make your model amazing is to have all the data. So they have all the data. So all of the healthcare data gets fed into their models. So they have like really smart models. It's amazing what they are doing. Really, really cool. And 0 to 1 is Peter Thiel, the guy started PayPal with Elon Musk. Really, really cool, fantastic book to read. So, yeah, that's me. I'm going to be here for 3 days, or tomorrow and the day after. If you have any questions, or if you want to talk about something, I couldn't share all the regulatory stuff in a couple of slides. And I also don't have all the answers, but I have people on speed dial that I can phone. Yeah, so happy for you to ask any questions.
Wow, that was phenomenal. Thank you so much, Adrian. I think we have so many people thinking about questions. I know some of our startups actually were or are building digital medical devices, but I'd love to hear from the audience. Do you have first questions around? Everyone decided to not build devices after seeing that presentation?
Thank you very much, Adrian. That was a very good presentation. It kept tickling me at many points. My name is Richard Kalunji. I come from Kampala, Uganda, where I've been trying to work on a startup called Home Doctors Uganda. It didn't really have a lot of digital in the beginning because of what you are saying, because our people were not really quick at taking up all these solutions that we keep building. But over the years, we have tried to see how we get what we have been trying to do in the community being digitalized, or really getting some bit of digital aspects to it. But my question is, as innovators, as we come up with innovative solutions, digital or not, because we know the challenges, we know that, there's poor access, there's lack of affordability and all those things. What really comes first, or do all these things come together? Because you have an innovator who is really pregnant with an idea, and they really want it to get out there like the men you've presented. There's a problem in the community which is really well known, but there is also a stakeholder or an audience you're producing for, which perhaps will not think at the level that you're thinking. So yes, you think it's a good idea, but they may not take it as fast as you've produced it, and yet it must become make business sense for you. And then there are the regulators that are talking about, regulating you hard on how you produce solutions, but not regulating the market or the population just as hard. So you're producing a solution, maybe a medical drug, but the community, for example, in many African countries, can still access any solution or any concoction on the market. So that's a confusion in my head around how do you get all these beautiful ideas out there, work with people like yourself and many other partners to really scale it up and it makes sense in the community, but also ensure that people pick it up and use it with support of governments and collaborators and all those things. I don't know if I make sense.
No, I didn't switch it off, I promise. No, the great questions. I think that is something we struggle with as well. So I'll give a couple of answers. I think one thing around the infrastructure, that because the community quite often struggles to consume our solutions and our apps and the things that we build, because they don't have the means to access it, because they don't have an iPhone or an Android smartphone. So there, I really am hopeful about the positive impact that technology like Starlink and like the guys from Amazon will make with their low level orbit satellite constellation with this. Say again? Yes. I think that's going to be really impactful, just to see how you can deploy these satellites in communities and how they can access and consume these solutions. I think say we solve that problem, how do you ultimately get the community to use it? We've also struggled. I think if you go bottom up, where you try and commercialize it and try and sell it to them, we've struggled. We've struggled with that. But our new strategy is rather go top down. We work closely now with these non-profit groups or these philanthropic groups, and also with the Africa CDC. If you can somehow make this solution, you can turn it into policy, or you get endorsement from a big group like that, I think then obviously the adoption is a lot easier. So we also struggle with that. I don't know what the answers are yet. around how do you make sure and how do you make it easy for people to adopt the software. And then around the regulations, it is, thank goodness I'm not a regulator. I know there is immense work being done, so they're busy setting up. So in Europe, they have something called the European Medicines Agency, where it's a group of, obviously they represent the entire continent, and we as Africa over the past 2 years, but really now this year and next year, there's really momentum around establishing the African Medicines Agency. And it's going to be, yes, in Kigali. And I think they will make a big impact because I think some countries really have great regulations, like Rwanda, like Kenya, South Africa, Egypt. And I think a lot of the smaller countries struggle to keep up. So I think if you have a big group, you have a wider impact, bigger reach, there you can make an impact, but still people can use any kind of product on the market unregulated. That is part of the world's problem. Yeah.
Thank you. Wilfred?
Yeah, thank you so much for that enlightening presentation. My name is Wilfred, co-founder, CEO at Virgo Africa. We are a healthcare business incubator out of Nairobi. And we work a lot with medical devices in Uganda, Kenya, Tanzania. And what we've learned in that clinical trial process is how different the roadmaps are from one country to another. Like it's not an A to Z that you do it in Kenya like this and Uganda you do. It changes. Sometimes we've had to map those processes on behalf of the startup. And I'm wondering now, building on top of what you're doing with Africa CDC on the clinical trial side, I think there's a need to map the process flow for each of these countries or streamline it so that it becomes so clear that this is a start point when it comes to regulatory, this is a midpoint and end point. I don't know whether you've given that a thought or whether you've had any experience in that. Thank you.
Great question. So we quite fortunate that we've been selected to help digitize some of these national regulatory agencies with a platform. So we've worked with a Nigerian agency called HealthTech. We're busy with a South African agency. And then both of them, there's a group called AVOREF, which is sort of a subdivision of the WHO. And they have come up with standardized templates that can be adopted across many countries. And these platforms that we've implemented, we've used those templates. So that is becoming the foundation of the African Medicines Agency. So hopefully within the next 3 to 5 years, it will definitely be that if you do a medical device application in any of 20 countries, it will look exactly the same. That is where they're going towards, this harmonizing of regulatory processes. It is not easy. Once again, I'm glad I don't have to lobby and a policy maker and things. We're the tech people, we're behind the scenes, but I think once they agree on a specific template and a specific workflow, for sure, that we can implement, and then also we'll make it. I think it's the CTC.Africa, that other platform of ours, or not ours, that we've built with funders' money. In there, I think, to define the specific workflow so that people understand how it works in different countries, and hopefully over time it will all look the same. That's important, so I'll definitely take that home and we can map it out nicely.
Thank you. Hi, I'm Pablo Sandofemia. I'm one of the founders and the CEO of Bridge for Billions, one of the implementing partners of HealthTech Hub. I had a question about when you think about, I'm also a founder, and the journey of entrepreneurship is something really, really tough. And particularly in the healthcare industry, in all industries, I will say, but specifically in the HealthTech, when I speak to HealthTech founders, I see that the mental health of the founder is the one that they look at the least. So I wanted to ask you, what are some of the lessons learned or tips that you've had in your journey that you can share with us about how to take care of the mental health of yourself and also your team that you lead?
Bro, that's the best question so far. So our motto in our company is that culture eats strategy for breakfast. So it's that is our thing, and it's important to us. It's going to be a difficult thing for us to maintain as we grow, but that is sort of in our sort of mantra. But to take care of myself, what has worked for me is to follow a healthy diet. That's definitely a thing. I try and exercise 4 times a week. I think those endorphins, it's a good thing, but still. You work quite hard, and then I'm also a husband to a wonderful wife and 2 small kids, and all of that comes on top of the fact that I'm part of 7 businesses. So it is difficult. I've once again I would surround myself with amazing people. Don't be too worried about giving equity away, but build a fantastic team around you, because you can't do it all yourself. In the beginning you can, yes, but before you know it, you can't. So that's also what I've done. I've headhunted people around me that I've met, and I've given them equity in our business, because I know, what is that thing that everyone says? 70% of an apple is worse than 20% of a watermelon. So that's I'd rather sharing is caring, and so we build that culture. Am I perfect? No. Do I struggle? Yes. But I think these, like healthy diet, exercise, and surrounding yourself with a good culture and a good support system, those are the things I'm doing. The moment it's working. Traveling this morning, I had to come here at 3 o'clock, and then my flight was delayed to 5:30. So I got here at 9:30. I didn't sleep, but now I feel good. I've had some coffee.
I think we're getting a new idea for a new app for entrepreneurs, a healthy living app and mental health app for entrepreneurs, from founders to founders. Any other last questions?
Just a point.
A point from Niti?
Just a point. Just quickly on what you said about mental health. I think it's so important. I've been an entrepreneur myself. I've lost all my money. I'm just putting it out there. I was very poor. I didn't have money to buy an Apple. No, I lost it because I didn't know who was paying for the product. So it's I learned a lot from that. But on the mental health side, I think it's such a good point that you raised. I think there are so many entrepreneurs in this room. If you want any mentorship from me, it's free. You can come. I'll tell you what I did and how I've managed. So just a point. It's a really, really good point.
Me go to Nitya. She's not joking. Well, thank you so much, Adrian. This was amazing. Go find these men in the next 2 days. Today was sort of a soft launch, and I want to say we're kind of starting with the heavy topics, because we have to start with the difficult things first. And we have a work stream that looks after regulations and policies, and that's probably the most difficult challenge of the African continent, of harmonization of regulations and policies, which touch upon licensing your product, bringing your product from one market to another, potentially using a technology sitting in one country, but you want to use it in another country, and interoperability. So on that note, I would love to invite a very good friend on the stage, Mark Landry from the Global Fund, to talk to us a little bit about interoperability and digital health. Mark, the stage is yours.
Good afternoon, everyone. Certainly a pleasure to be here, and like Adrian, wow, this is such a special environment for all of you startups and scale-ups. I am returning to Kigali after 15 years. I was here in 2008, and has this city grown and transformed itself. It's just remarkable. What I wanted to do actually is I'm going to give you something to think about and a question, and I want to have a discussion. I just have 3 slides I want to share with you in the spirit of what we're seeing at the Global Fund and how these trends might actually impact your thinking about being future-proof with your amazing digital health solutions. So This title of this is a play on words: sink or swim. Navigating the digital currents of interoperability for patient-centered care. Now, in this case, you want to sync, S-Y-N-C, sync. You want to be ready to interoperate and make sure your solution is not in isolation and is actually part of a broader ecosystem of solutions that are empowering citizens and patients and providers, et cetera. And you don't want to be swimming. You don't want to find yourself constantly swimming and chasing and trying to make your product and your solutions more attractive because you're not in position to be what we say a level of interoperability readiness. So the question I want you to think about as I just go through just 3 slides is, in this ever-changing digital health landscape, how agile and adaptable is your organization in adopting and implementing different types of health data standards so that you can make sure your solution is seamlessly interoperable to improve and better patient-centered care and service delivery. So I'm just going to share a few resources with you. What we're seeing with our investment, so at the Global Fund, we go through these 3-year funding cycles, and we have estimated that we're investing on the order of $150 million US per year in digital solutions among a whole array of countries and portfolios, mainly to eradicate HIV, TB, and malaria. Due to COVID, we've also been investing more in pandemic preparedness and response, as well as different components of strengthening health systems. And all of the countries that we work with, almost universally, have some kind of a strategy, a digital health strategy, a health information system strategy. And what we're seeing now is this urgency to operationalize that strategy through implementation plans and action plans. And this is being done through what's circled here in the middle. Countries are learning by doing and developing what we call an enterprise architecture blueprint. I heard somebody was here from Uganda. Who's here from Uganda? Okay. You look very young, but I even remember 10 years ago, your country put in place an mHealth moratorium. They told developers, stop building these apps and solutions because the government had no guardrails for absorbing and being able to sustain and support this emergent ecosystem of disparate mHealth solutions. And so in Uganda, you know the rest of the story, right? There's now good governance for making decisions on what can be implemented and sustained because at the end of the day, not every digital solution that goes into a phase of piloting, not all of them are worthwhile, to be honest. You learn by doing. But the point is that having this architecture blueprint becomes a way to empower all developers to understand the rules of engagement, understand what standards are needed to improve your ability to be interoperable ready. And so this is a guide from the WHO, and just tries to highlight the importance of this as all of our intentions in public health, digital health solutions are usually genuine with an intended health outcome and impact, but at the end of the day, they have to be part of a broader ecosystem of interoperable solutions. Anybody familiar with this diagram from the Open Health Information Exchange? Anybody seen this in their work? Raise of hands. Anybody familiar with the Open Health Information Exchange architecture framework? Very few. Many countries in Africa are subscribing to this kind of an approach where you might see yourselves down here. You might have some kind of a point-of-service solution. But how well are you equipped? How well are you adapting and adopting and embracing standards so that you can create ways to interoperate with adjacent point of service solutions, or be ready to share data with other systems, whether they are open source or not, or proprietary. And this is the sweet spot that I'm going to get into now, because to create this health information exchange environment, we have to have a number of reusable assets, including working towards having a library of terminology services or health data standards, common use of unique IDs for patients so that they can be tracked through longitudinal points of care and services throughout their life, for that matter. A common use of health facility registries, community health worker, and other health worker registries, product catalog. All of these are important services, as well as others in terms of different types of shared health record and logistics, etc. And here you are. Here are these reusable tools. This is what's emerging in many places, particularly here in Rwanda. Rwanda was one of the first countries to embrace and initiate this open health information exchange architecture framework. Back in 2007, 2008, the leader of digital health here, Richard Gakuba, the Rwandans in the room will probably recognize his name, started to implement this. But here's where the rubber hits the road. And this is a document that just got published by the World Bank just a couple months back. And it's an implementation know-how guide. And I strongly recommend, when you get a chance to get this deck, that you download and review this, because it is going to help you understand how to, again, create an awareness for yourself as an entrepreneur and get your system solution into that swim lane of interoperable readiness so that you can be prepared to scale, to sustain, to exchange data with other systems and solutions. This is just a nice graphic that's in this document. All different kinds of standards that are necessary, both semantic, which means the content, data's around the data and information that's being shared. Of course, syntactic, about the attributes of that data that's moving about, and even technology standards that are critically important as well. So my question now for the group is for discussion. I want to hear from you. What are some of the challenges and pitfalls and issues that you have faced to embrace and utilize health data standards? And then maybe others in the room might have had that challenge and have solved it. So please share, what are you doing as a company to be interoperability ready, and or what are some of your pain points that you have addressed? So I don't want to make this a session about complaining and framing the issues. We want to talk about solutions. What are you doing to be ready? What have you tackled and obstacles you have overcome? And or put it out there for others in the room to share their experience that you can learn from. So please, I see a first question or comment here up front. Go.
Hi, really excited to be here. There we go. Hey, my name is Rob Coram. I'm from Penda Health, Chief Medical Officer. I've been working in Nairobi for the last 8 years with Penda. We do primary care, and we have really faced the interoperability problem. And one thing that I would say is that if you look at it through the lens of technology or data, you may be missing a very important lens, which is the incentive lens. So number one, incumbents do not want to lose their patients to newcomers. And so they are actively disincentivized to allow flow of patient data out to any new startups or competitors. If I think about Penda's own journey, insurance companies, this is a huge pain point for us, the interoperability with insurance companies. They do not want to make it easier to submit claims. And so I think any discussion about interoperability, we need to think about those incentives. And to your point about solutions, I would really just say I think regulators need to come in and say, everyone who wants to play in this ecosystem has to play nice with the other kids. You have to follow these standards. You have to put data in this form. Otherwise, we're not going to allow you to operate. And I think it's through that kind of very serious regulatory approach that we're going to be able to get a lot of the new startups coming in and being able to come and offer innovative solutions to people who are, behind the walls of the incumbents. So,
Great point. So we need incentives, we need a carrot, and we need regulation. We need a stick. And I will tell you as well from experience working with many countries is it's not the technical interoperability, it's actually the organizational interoperability. It's having a friend that is another system owner that you want to interoperate with, and then you agree to work together and finding that win-win, that mutual benefit between that data that needs to be exchanged. We're seeing this with our grants, and it's getting to a point now where we don't want to tolerate this fragmentation, siloed approach of systems and solutions. And so this is to your advantage to tackle this head on. And remember, you might think you have that next big thing, but make sure you're on that edge of being ready to interoperate, and know that the challenge isn't your solution. It's probably soft skills like your communication skills, your negotiation skills, your ability to coordinate and facilitate those kinds of discussions. Another comment. Let me go here because he's got a mic in his hand, and then. Okay, somebody. Okay, go ahead. Sorry, you had.
Hello, hi. My name is Jide. I run a startup called Render Health Technology, and we are a data analytics company where we get the insight behind health data via payment via a product called Render Health Savings Card. And I want to piggyback on two things that people said here. That doctors are one of the most challenging people to work with. Yes, Niti, you're one of them. I'm just kidding. And that is one of the challenges. I want to talk about some of the challenges we face because so I launched a company in 2018 with a background in clinical research. So everything he said, I was very familiar with that. And when digitizing, we built an EMR to try to digitize. And what we noticed that doctors will tell you, we took a draft from a public hospital in Lagos, and we digitized with that standard. And we went to a private hospital, and we showed them, and they said, no, this is not how it works. It should work this way. It should work that way. So we find ourselves as digital founders, entrepreneurs, trying to solve healthcare problems. And the people you want to solve the problem for, the whole group does not have a standard. So going to what Robert said, I think a major thing that needs to happen is there needs to be a baseline regulatory format or something like that. Because that would really help. Because if you go from healthcare so now predominantly we don't work in Lagos anymore. We work outside of Lagos, and even outside of Lagos, there's still different healthcare facilities that will tell you this is not how it's supposed to work. I do this first, I do that second, I do that third, and you go somewhere else to say, oh, this is not how it's supposed to work. So the doctors who are supposed to be using our solutions don't have their mind made up on how things work. So I think that's one of the challenges we might have, and I think hopefully regulatory could solve that someday.
Excellent point. And I'll share a country that will not be named here in Africa. Their digital health team, they have transformed themselves. They used to be about developing software and maintaining these systems, but now they are reinventing themselves to become basically a policy hub to set the rules and protocols so that everybody can play together and have set the expectations for all of those actors in this space. So again, it's urgent that government plays a role, whether it's through regulation, whether it's through policies, to shore up a set of common agreed standards so that everybody knows how to be prepared and how to tackle this issue of interoperability. Now to you. Thanks.
Yeah, hi. My name is Faye. I lead the team at Cloud Equipment. We're actually helping healthcare facilities across the continent, but starting from Nigeria, to get medical devices in their facilities at zero upfront cost. To be able to do that, we do a split of the cash flow that comes from that particular equipment that we're placing. I'm going to talk about something you mentioned, which I see is a quick win. It's around leveraging what other startups have done and more partnerships versus building in silos. It's interesting that Jide talked, because we were having an interesting conversation, specifically because I am trying to drive financing for medical devices and drag investors into the pipeline of deals. My core is not EHR, it's not payments collection, and it's definitely not, getting information from the machines to the doctors. But these are areas where other startups have built and are very strong in. And so most of my conversations have been around those partnerships. You will still find a lot of resistance from startups who are trying to cover and hold on to their cookie. As a finance person, I've been in corporate finance all my life, aviation, maritime, and healthcare. I find it very strange that I'm talking to somebody and I'm saying there's a mutual benefit here, and most of the times they're like, no. So now I'm forced to go and look at open source EHR and EMRs, and I don't want to spend my time doing that. Like there's a nearly $200 billion gap that we need to fund for medical equipment in 2030. And I don't want to do EHR. I literally want to tell investors, your deals are safe when you come here, because we're able to monitor our facilities, we're able to collect the money, we're able to work with them in a way that works. And so back to your point, and not to belabor the point, more partnerships, more conversations around what is your strong suite and how do we then make money off of this? Because I think that grants and charity will not save Africa. I am one of those few people that detest the fact that we have to put out our hands every time and say, come and save us. I strongly, strongly believe that more intelligent business models, more intelligent financing models, more cooperation, not at the government level now, I'm talking about building levels, will be the things that make us win.
Brilliant, brilliant. And I think we have to remember, and I don't have the statistics, but I mean, we all know that the digital health market in Africa is exponentially, the potential is enormous. And, stop worrying about cutting out your slice of the pie. Grow the pie, right? I mean, everybody wins. And, take for example, the Director General of the WHO. He has been quoted as saying, the future of health is digital. So it's only, fair, and it is a joint venture when you partner. There's risk, but the potential is much greater than doing it alone. I really appreciate that comment.
And just to piggyback on that, last week we had the IQVIA summit, and the topic, exactly what I was trying to raise there is that there is a space for healthy competition and healthy collaboration. So that's this place. That's why we have over 68 companies in our cohorts, and we're growing this community. We know how many of you guys are partnering, and this is what we want to see: complementarity, value sharing, not only with big tech players or governments, but also between each other. That's where the beauty is, and we have one of our startups that's going to come from that.
Thanks. Thanks. So I feel I have to. My name is Dr. William Mapham. I'm a rural doctor. And I feel I have to come to the defense of the clinicians in the room.
You didn't get any boos, so that's good. No boo birds.
Yeah. The average time we have for a patient is between 8 and 10 minutes per patient. So if it's not good enough to solve a problem in that time, it's just not good enough to use. It took us 2 years to make our system simple enough that people actually wanted to use it. And speaking to your point, we had to customize it. And so initially I kind of hardwired and said, you must use it this way. And then we made it free, and they could do what they like, and they actually found ways to use it that I haven't even imagined. But customization was key. But then the problem with customization is if you do have 110 forms for different clinics, how do you structure your data in the back end? And I took a picture of your slide there, because then making sure that all the standards meet is much harder. So we've got kind of a data problem now. But obviously as a doctor, you get free medical advice while I'm here. I'll try and make it easy for you to work with me. Each have 10 minutes. But it's been a real challenge. And I think the one thing that we struggled with is that departments of health wants to work with us as long as we paid for the integration. which we then did, but it's expensive, and then you have to carry on. And yeah, it's exciting to have some funding from the Global Fund through one of the partners here. But it's also key for us to find people who will collaborate, because at the end of the day, you do need private sector solutions and funders. And the one thing that we found is the pharma companies are completely incentivized to improve the healthcare system. So there's no point in sending drugs for sickle cell disease to Ghana if no one's going to use it. So actually, Novartis will fund sickle cell disease programs in Ghana. So I think if you are looking for private sector funding to improve health systems, there are options available. But again, it took us 4 years to find some. So I'm happy to share the experience, yeah.
Great, thanks for that comment.
Thanks for the presentation. My name is Shiva, a founder of Digital Realm. We're not particularly, from the ground up, we're not a health tech care, but one of our products is in healthcare because of our cross-sector strategy. So what I come with this is that, first of all, from a technical standpoint, computers can always find a way to speak to each other, as long as there's a will from the organizational perspective for those building those systems to want those systems to speak to each other. So interoperability is within the fundamental pillars of the way computers work. So if we don't want them to speak to each other, they won't. So what we figured out is when we were building our first pilot, we're still working on it. There was all of these API accesses. The moment you want to reach out to a stakeholder for a partnership, they're like, okay, we'll work with you, but in the end, you realize there's a partnership incentive and ulterior motive that we work you with for a year, and then the moment we realize we can duplicate what you're doing, we end the partnership. And the startup culture most of the time is built around build a walled garden and compete, and a lot of the time we waste a lot of energy competing, and then a lot of duplication happens. So who enforces that interoperability and collaboration? Because at some point, these startups are going to outgrow the capabilities of Novartis to be able to enforce that. So how do you ensure collaboration and interoperability in the future?
Yeah, I think innovation is always organic, and you're right. I think the private sector is not only under-tapped, but has exponential potential, right? And again, I think it comes down to declaring these rules of engagement through a set of declared standards that need to be adopted or utilized, right? So I think there's a role of government here. There's also a role for the private sector to expose your learnings when you are engaging in these bilateral joint ventures with other technologists. And I think another thing that is emerging that the World Health Organization has started to develop is they are taking their clinical care guidelines and putting them into a format, what they call our smart guidelines, or computer readable formats that will ensure that you are satisfying the best practice of a clinician and adhering to that using packages of standards like HL7 FHIR, ICD-11 for looking at diseases and classifications, other standards. And so once you continue to grow and innovate, we encourage you to think about clients such as clinicians as long as you are not only complying with the standards but complying with the good practice. I think you'll always be in that swim lane of good practice, and you'll attract more opportunities for continuing to grow your solutions, but also to be able to interoperate with other technologists as well.
And
other comments?
And maybe just to add on that, we have some good news for you. As you know, one of the 5 strategic pillars of the hub is our work on creating a policy blueprint to fast-track health tech innovations, which is nothing else to say that from all the funded and supported by the HealthTech of Africa acceleration initiatives, such as the one of Vula, for example, we learned quite a lot, and we just channeled the voice of the startups and the scale-ups when it comes to key priority areas, which the governments have to actually sit down and agree on. And interoperability is one of the 3 prioritized areas for us next year. So we're going to be working with this whole community and with a number of governments on the same table to see how we can move the needle, not only into very country-specific initiatives to drive policy roadmaps, but also regional, so that we can not only innovate in terms of APIs, technology-wise, but also accessible partnership integration. Maybe a new term for that.
If there's already a level of interoperability within the hub startups already, the systems are already being built so that it's built from the ground up, not something that is enforced.
I think that, Mark, you're going to have a homework for next year.
Well, I think there's already discussion about this idea to have some kind of a sandbox and have some way, where you could have a connect-a-thon environment where, the hub can create building on your existing tools and platforms, a safe space for teaming and tooling and testing and training and tech transfer, the 6 T's.
And we do have an open source library where we host key assets, so use cases, case studies, tooling, frameworks, best practices, also including into the actual due diligence process. Every time we actually fund a company, we give them certain requirements, and this could be one of those. So great idea.
On the digital system side, because it's all digital solutions, and the moment they all don't work together, as in the beginning, it's always a silo, like a walled garden. So the moment all of those walled garden, they're not speaking to each other within one hub, sometimes in the end, when they're all too big to actually comply to one another, it becomes a challenge.
That should be definitely a top priority. Also, back to what Bill was presenting. In order for us to create these algorithms, we need more data that's flowing, through the systems. And to do that, we need more interoperability, not only just separate silos. Absolutely. Two questions on the top. Please present yourself.
Hi, my name is Brian Sanoga. I lead the team at Guild Digital. We work in community health. And I think one thing that's worked for us for interoperability is to start with a digital public good. And so that's ensured that a lot of the standards and a lot of the things we would be struggling with at the technology level have already been sorted out. So reference workflows or care plans or standards in the software, the way the repo is structured, and just all of that has been figured out by your technology steward. And so all you're doing is the last 20% to adapt the tool to fit the particular context you're using.
Great point.
Amen to that. Hi, I'm Rubaiyat. I represent an organization called Endless Network. It's a family foundation in the US. But before this, I was co-founder of an organization in Bangladesh that is now scaling up FHIR to about 120 million people. So aside from the points already raised around incentives, and I think layering on the incentives problem is the question of who actually pays for that interoperability, because especially in VC-funded startups, VCs are never going to pay for interoperability, right? Like they don't care whether it interoperates. They probably just care about getting that to scale much more faster. And sometimes interoperability actually slows you down. So that's also another challenge. But I want to kind of move back one step and also ask the question, if we're talking about truly people-centered care, shouldn't records and like especially patient health records, shouldn't they reside and be owned by patients themselves? Because right now, the way we're even imagining health systems, and I think this has been a continuous phenomenon all throughout the history of public health, we've designed systems around providers, right? So if we are really thinking about people-centered systems, records needs to stay with the person continuously throughout their lifetimes, and we're not designing systems right now for that. So just would love your thoughts on that.
No, certainly that is, I think, a shared ethos that we have at the Global Fund. That, of course, I think ultimately your health is your business, and your information, you are the owner and steward of that. In fact, through a next generation catalytic fund at the Global Fund called the Digital Health Impact Accelerator. Some of you may have heard that already. One of the investments we're making is here in Rwanda, where they're going to be taking the open health information exchange architecture and working towards a citizens health portal. That's the ask in that particular engagement, which is exactly to your point that we have to also focus on other aspects, not just the standards, but also protocols for data security, privacy, and confidentiality. Anonymizing data when it's not necessary to have any of that PII, personal identification information in any of that is shared. So we're also a learning organization at the Global Fund, but these are becoming more and more very clear next generation public health investments into the shared health record and the person client-owned dimension of that becoming more and more critical. I'm letting others figure out who's next with the.
Sir, mine is more of a follow-up on two of the conversations that we had. So first of all, I do agree about making a platform much more flexible to allow providers be able to kind of change it. But the problem with startups are small, right? So I'm working with a hospital and they say, oh, we wanted to work this way. Let's customize it. By the time it's customized, the hospital already abandoned, and now you have to start from scratch. So that is kind of one of the things, because most startups are trying to run lean, especially in the health tech in Africa, where there's not a lot of funding for you to scale your team and build really, really fast. So by the time you tell me this is what you want and I try to build it to you, you're no longer using it, and I have to start the sales process over again, or there's another competitor that is going to face the same issue I face trying to close you. So I just wanted to kind of follow up on that. And on what you said about patients owning their data. So that's kind of one of the things we're working on with our solution, whereby patients can actually log in and see the medications that have been prescribed and the services they received. But the kickback we get from providers and doctors in Nigeria, I'm not going to speak for other parts of Africa, is because anyone could walk into a pharmacy and buy medication, unlike other countries in West, whereby you need a prescription. Providers fear that when patients are able to see their record and see the medication, they will not come back to them for services. So they will look at, the last time I went to the doctor, I had a cough, I had a sore throat, and I had this. So why would I go back to you to prescribe me the same medication? I'm rather going to save my consultation fee and take that consultation fee and just go buy the medication you prescribed me when I had the last symptom. So it's kind of we're kind of having that conversation as, should patients have access to their data? Because if they have access to the data, they could self-prescribe more rather than going to the doctor to get consultation and think, okay, maybe this is not the same diagnosis and the same medication for this treatment. So just wanted to piggyback on both of you. Thank you.
Yeah, that's not an issue I can solve, but maybe the doctors in the room could speak to that. But I want to speak to the former point just very briefly. The more customization you do, the smaller your client pool becomes, right? So to the point that was made earlier, start with a digital public good and then customize the last 10 or 15, 20%, and then that becomes more reusable. So one of our doctors want to speak to us.
Not on that one, because that's a can of worms I'm not opening up here. But just quickly on the patient and the consumer, and just on the, I used to sit with the EMA on the European Medicines Agency on their devices. You really need to think about what your users are going to do in that regulatory framework. Because what happened was the type 1 community, I don't know if you heard of the type 1 looping community, the loop systems have come about as a result of the patient being in that conversation on regulation and making sure that regulation was pushed forward, not backwards. So I'd really, really recommend that we think about how the user of services and the user of some of this tech is in that regulatory conversation.
Excellent point.
Yeah, thank you very much. Just to build on to the doctors really defending their service. I feel that through my experience practicing as a doctor, I feel that denying patients information does not exactly get those patients back to your office. And it's even made worse because in our communities, everyone can become a doctor in quotes. You can find someone seeking care from someone who has never been to any biology class. Or
Dr. Google.
Yeah, I am. So, and then it's further worsened by the fact that someone can buy practically any medication they want. So what I see is, on the side of innovators and entrepreneurs, we may want to really do what we're talking about ourselves, so that it finds the patients doing whatever they are doing, the practitioners hiding the information from the patients, and they are forced to get into whatever loop it is that we shall form. Because if you look at what we're trying to do in terms of making information accessible, that information may be about the patient, or it may be about really general medical care. How do you diagnose this disease? How do you manage it? The more you make information available, the more patients come closer to you. And if you have so many people doing it, then those who don't want to share it are equally forced along the way to start doing it. But I really don't feel that anyone hiding any information anywhere has any impact on reducing self-medication or reducing irrational drug use. Perhaps it's even just worsened by that. Yeah.
I think we still have another 5-6 minutes or so.
That's your last chance to speak. Last question or comment.
Good evening, everyone. My name is Eric. I'm a medical doctor. I'm a fresh graduate. I just started working just a couple of weeks ago. This conversation here was pretty interesting to me, and it gave me an insight, and it made me want to say just how we are as medical doctors, so as health tech people, you know who we are dealing with. For the last 6 years in medical school, they teach us to be diligent, cautious, and evidence-based stuff. And I think interoperability you're talking about, your technology it has to interoperate with our hands and our minds. And the problem, I think medical education has not caught up yet. Honestly, I remember like when I was in internship, my senior doctor saw me taking notes in a phone and he was really mad at me. Taking notes with the hand, with your pen. You see, there is even a generational gap between young doctors and the elder doctors. So I think there is still a gap in synchronizing our medical education and new technologies to make interoperability really possible. So I think as like an artist and this whole advocate for health tech, I suppose there should be a modification in medical training. I came here because I really care about technology and I know how it affects my work. Like when I was working in internship, I wrote files with a pen. When I started working in a hospital, they told me, no file anymore. You have to write every data in your computer and those stuff. It's really, I'm expecting more surprises as I go. So I think to improve this interoperability between technology, health tech, there should be also a sync with the medical education. Thank you.
Excellent point to conclude.
A small comment on that. I cannot resist. So one of the key recommendations, which the last two broadband commission reports, not going to go into what that is, but high-level policy reports focusing on virtual health and care and the utilization of AI in health. The key recommendation, one of them was really embedding, essentially speaking, digital health and AI knowledge, if you want, or curriculums within official formal education. This was one of the key things, because otherwise you face exactly what you face. One of the good news around is, for example, how the HealthTech Hub is engaging with this, or trying to engage with this, or influence this side of the puzzle, is by also having an academic partner community of partners. So, for example, we work with the University of Basel as one of the partners that's kind of in touch and partnering with a lot of the African universities. And we just signed a partnership agreement with the Global Health Equity University, which is going to try to really prepare everyone who wants to be on the entrepreneur journey or the innovator journey inside of the health system, as a doctor potentially as well, to learn what are the skills from that digital and innovation mindset before then you can enter the HealthTech Hub Africa. So these are some good news for you.
Great. I want to thank everybody for a rich discussion. We didn't solve all of your interoperability
we have 2 more
challenges, but please be thoughtful about getting your company better prepared, because again, it is for all the reasons we talked about. I think you heard some good solutions. You heard some of the challenges, but some of the ways to resolve those issues. Just invite you to look at those resources I shared when you have a chance. And good luck. And remember, the pie can be grown very big. Don't fight for your slice. Fight for the pie to get bigger and bigger.
Thank you so much, Mark.
Thanks all of you for your interaction. Thanks.
Thank you, Mark. I have good news and I have bad news. So the bad news today is over. The good news, we have 2 full days ahead, which are going to be focused on our entrepreneurs. We're going to first get a little bit of clue about what's the situation within Rwanda through the Rwandan Medical Association perspective. We're going to also then zoom out and look at the Africa investment landscape with our partners from Viogro Africa, who are going to lead the session on that. And then we have a full 2 days around talking about investments, showcasing some of the best funded companies and organizations within the HealthTech of Africa cohorts, and hearing some of our startups. We're also going to have additional keynotes. We're going to have a panel around sustainable financing and more to come. So I do wish you to have a really good sleep, because we have an early start, 8:30. Please be on time so that you can benefit from all the networking opportunities, because it's really about sitting in front of investors which come from different places, different hats, from VCs to angels to banks. And we have some very interesting announcements talking about international development banks, hint, and more. So please prepare for tomorrow, be here on time, and looking forward to continuing the dialogue. Have a good evening.